is it that we do? I mean, if we think about pediatric palliative care as, a tangible group of tasks that we do, these are some of the things I'm sure you will agree with. So we help patients, families, and care teams do problem solving and decision making. We also help in identifying goals and hopes regarding the disease at different points in the disease trajectory. We also support everyone involved in care to think about the pros and cons of a variety of treatment options available, and this becomes often very complex at the end of life. We definitely try to improve the quality of life and minimize suffering, whether it's through the management of physical symptoms, psychological distress, or spiritual distress. And we try to do logistical support around maybe providing equipment or practical advice around the patient being wherever they might choose to be. But that's a fairly tall order. And it might be slightly difficult for those of us who might suffer from vertigo, and that happens to me sometimes, and it's too dumb. So that's why we can't do it alone. We cannot be a single member, we cannot be a single clinician delivering palliative care. It has to be a team. So who are the team members? And this might look slightly westernized, but I've been in my job in Cipla only for the last few days. And this is more based on my previous experience where I was working at a pediatric hospice in Kuwait. So there are the physicians, nurses, and I think the rather important members of the team are the people from the psychosocial support team, who may be psychologists, medical social workers, child life specialists, chaplains, music therapists, play therapists, bereavement support workers, and the allied health professionals who are physiotherapists, occupational therapists, dietitians, SL, speech and language therapists, and so on. Add to that, also engaged in care are the clinicians who are the disease specialists, so the oncologists or the cardiologists or neurologists who are referring the patients to us, or sometimes, rather often, they're not referring the patients to us. And at the center of all of this is the child and the family. Of course, there's the palliative care physicians, and the people I haven't mentioned here is the pain specialists. Can I quickly ask whether we have dedicated child life specialists in India now, or we still don't?
We have very few child life specialists in India.
Very few. And do we know how they got?
We do have child psychologists. And
right.
We have dedicated. Like in Cankids, we have psychologists.
How they differ, child psychologists and child life specialists?
So child life specialists have a particular specialized training, which as of now a certified child life specialist can be obtained based on still an internet-based learning with internship and with a trained CLS.
Is more on different interventions. Psychologists they focus more on counseling.
So I had the wonderful opportunity of working with a very distinguished CLS in Kuwait, and if anyone's interested, maybe we could look at some networking there. So these are wonderful people to work with, and they're the happy people. They do the play and developmentally appropriate communication tools and distraction and so on. And what are they trying to do? They're trying to promote the optimal development of the child through the disease trajectory. And even though we are mostly focused on cancer in this conference, keep in mind that pediatric palliative care does cater to a much wider group of children outside the oncology specialty. They help in educating the children as well as their families around the health condition and what's going on with them. They help prepare children for medical procedures. They use coping and pain management strategies. They help children express feelings, again in an age-appropriate way, in a non-threatening fashion. So one piece that we did with the child life specialist was we had a patient who enjoyed playing Uno. And he played Uno up to the last few hours of his life. And we got talking about his feelings about dying simply when he said, "My favorite color is yellow." So why is it yellow? It's because the angels in my aunt's garden are painted in that color. So that's really the expertise that a CLS brings, to pediatric palliative care, and I think that's absolutely precious. They help in establishing therapeutic relationship with patients as well as their families, and also cater to siblings. So the CLS may be that one key person who's able to support siblings going in to see a child that's, very sick or has just passed away, and be able to do it right. So these are wonderful people to have in a palliative care team for children. Quickly looking at the pictures, there's the first one on the left is they're doing some medical plays where the child has an opportunity to use the stethoscope and feel medical equipment. And again, you can see that they're useful across different ages and stages. So that's the little person there doing some nebulization, I think. And the third picture is doing some distraction, and that's probably a virtual reality, a high-tech sort of a projector with 3D figures that come out, and children can reach out and pop bubbles or catch fish while they're getting a procedure done. If that's not available, use soap bubbles. That works as well. So the other wonderful people on the psychosocial team are psychologists. A lot of psychologists with understanding of developmental psychology or educational psychology are typically people who go into the child-led profession. And there are medical social workers who are able to identify the needs and advocate and identify resources within the community and outside. Music therapists, again this is referring back to my experience in Kuwait, and I'm not sure to what extent music therapy is available in India, but it seems to be coming of age because I saw it become a music therapist on a billboard on a Pune bus stand. So I think it's quite popular. But these are wonderful people to work with as well. So using non-verbal distraction, providing comfort, providing stimulation to a child who's bedbound, being able to make memories together with the family. So these are some of the wonderful things that they can do. And chaplains. Again, this is, is it secular, is it religious, or so, and so on. But I think these are wonderful people who can come in to provide support around some existential questions, whether it's going through a particularly difficult phase, end of life, what happens afterwards. We have the wonderful lecture about physiotherapy in palliative care, so I'm not even going to go there. Occupational therapists, these are again folks that can help patients and families optimize their quality of life, optimize the way they do their daily living, and so on. And I think these are professionals who have to be slightly different to their counterparts working in intensive care or in acute care settings, because the target is always shifting. So a child who was very well might be very sick in a very short amount of time, and they have to be able to keep sight of that. Dietitians, I think we have a few dietitians in the group. Again, there was some of the work that we did in Kuwait where I realized the value of a clinical dietitian being there. And Dr. Tulika's lecture was very helpful to us this morning. And one of the things that I learned is hunger is a form of suffering. So while we may say that we may not, advocate for aggressive dietary management at the end of life, we have to keep in mind that hunger is a form of suffering, and the mother or the parent-child bond is based on this, this ability to nurture and to feed. So there's a lot of work that needs to go into dietetics, and what does it mean for the family emotionally, socially, and culturally. These are also folks who could help us, manage GI symptoms. It might be something as simple as constipation, or it might be someone who helps us, keep the gut going so that we are able to manage giving oral medicines to the patient so that they can avoid that admission into hospital at any cost. And what I've learned is, if the gut works, use it. Use small amounts of fluids, clear fluids, water to stimulate the gastric and the gastrointestinal action, and you could perhaps conserve the GI route of medications. Physicians, the most wonderful people. What would the world be without us? Well, no, not really, which is why they are, much later on in the presentation. And often I've found that my role in the team is usually, pushed to the background because the needs of the patients and the families are not really so medical or clinical as they are more related to support and doing what it takes to be a normal family. However, we do have a depth of understanding of different disease conditions, and we are able to put things into perspective. We have expertise in symptom management and pharmacological management of symptoms. And we should be the folks that also reach out to our other physician colleagues, whether it's pulmonologists, neurologists, intensivists, to advocate for palliative care and the palliative care approach to caregiving. Nurses, wonderful people again. I wish I would work with Leanne, but and some of the most wonderful people here. These are the people that are there by the patient's bedside for most of the time. These are the end point of care delivery, and I think what the nurses are able to do is absolutely vital. They're able to, have those difficult conversations. They're there to really understand what a patient is as an individual, what the families are, what their hopes and aspirations are, and to be able to support. So I think the nurses have probably the broadest scope of caregiving within pediatric palliative care. And then, of course, the disease specialists. I think we need to reach a point in time where it's not them, the oncologists, or it's not them, the neurologists, who are advocating aggressive treatments. But it's us working together as a team, and we bring in the palliative care aspects and educate and support some of the decision making around that. So that's, I think, something we should do going forward. So are the parent and the family a part of the team? I think there are different ways of looking at it. Some of us might say yes, they are. Another perspective on this is that they are not really a member of the team, but they are the people at the center of the whole teamwork that are guiding decision making, goals of care, and everything. And why are they not a part of the team? Because their experiences and perspectives are different to us. We are not their lived experience. We are not going through what they are going. And I think it's always important to be sure that we are aware of that distinction when we are giving care. They, however, work in close partnership with us, and they participate in decision making. And their role or their responsibility almost is to be able to communicate with teams about their preferences, values, and needs. And our role, therefore, is to empower them to be able to carry out that responsibility. A case study, and maybe we can have a quick round of what we think are the care needs of this patient. 9-year-old boy with advanced neuroblastoma, palliative chemotherapy possible for quality of life but not likely to prolong survival. Has symptoms of generalized moderate bone pain, fatigue, anxiety, anorexia. Essentially, the goals, as mentioned by the family, are around the quality of life. What do we think are some of the care needs? If we were the multidisciplinary team looking after this patient, what are some of the needs? What do we think? What are the issues? Pain management, yes. So management of physical pain.
Anxiety.
The management of anxiety. Anorexia. Anything non-physical.
Uncertainty, what is going to happen.
Absolutely. So uncertainty, and that brings us to decision making. The child insists on going to school. So these are some of the things, and this is something that we face on a daily basis. So I made a very small list, and I'm sure if this was a real case we were dealing with, we would have a lot more richness to that. So symptom management, decision making around taking the chemotherapy or not, supporting patient going to school and having as normal a life as possible, communicating with the child, the family, siblings, as well as psychological support for the patient, the family, and siblings, and ongoing support through death and bereavement. What would be the MDT approach? Obviously, physicians, nurses doing the pharmac management of symptoms, dietetic management to help with anorexia, fatigue. It might be engaging the child, making a particular recipe that he might enjoy, that he might have just 2 spoons of, but it's not just about eating the food, it's about the experience of going through the whole exercise. Relaxation, guided imagery, progressive muscle relaxation to manage pain as well as anxiety, and these are things that work beautifully. Physiotherapists are some of the wonderful, or the child life specialists, these are people that could help us with that. Expressive therapists to support communication, provide psychological support, and perhaps making memories. And working closely with our colleagues in oncology to support appropriate decision making, as well as bereavement care. I'm also going to talk a little bit about teamwork, because when we have so many different professionals who bring such a rich variety of expertise, it does become a little difficult. Well, yeah, so together everyone annoys me. It could be that way, or it could be together everyone achieves more. It's a question of perspective, really. So, as thinking in palliative care and team working has evolved, what has happened is that teams have tended to become more interdisciplinary. That means we work closer together, we understand one another's roles better, and to an extent we might be able to overlap roles. That's a good thing, but that also comes with a set of problems. So increasing collaboration among team members would help us shift from transdisciplinary. Transdisciplinary teams are typically where people do an allocated job but don't really talk to one another. It's very compartmentalized. Multidisciplinary is more about opening up to collaboration, having conversations, but is not as pragmatic as interdisciplinary. So I've stuck to the center and said multidisciplinary approach. So sharing goals of care, which are obviously driven by what the family and the patient wants. Having open, effective communication. So, maybe coming up to a team member and saying, maybe I'm not sure what it is I should be doing. What do you think? Is there anything from your expertise that I could borrow? And reflecting on work as a team and learning from those experiences. Team competence. We might be fabulous workers individually, but if we are failing as a team, then we're probably not able to achieve very much. So the concept of team competence is something which I have found practically very important in delivering good standards of pediatric palliative care. And it's based on commitment, an environment of safety, as well as an interdisciplinary collaboration and open team working. These thoughts really have crystallized out of the work of colleagues in Greece and in the United States. So commitment is the ability of the team to be committed to their work, their patients, and to one another. The holding environment, and this is something that I found fascinating as I was preparing for this lecture, is intentionally creating that environment where team members are able to express their feelings without feeling judged, without feeling criticized, feeling safe, finding comfort from what can be a very tough job, and from learning, from reflecting, and from being encouraged to care for one another and for themselves. Interdisciplinary collaboration and team working is about being flexible in terms of team working. So the team might look very different based on the need of the patient at that given point in time. So we are basically saying that we have teams where almost everyone is equal. So who's in charge? Who's the leader? And what does it take to lead a multidisciplinary team? Well, it takes a lot of virtues, or it could be a box of donuts. Choose the easy path, I say. Bring the donuts on. And what are the functions of leadership in an MDT? So it's about inspiring the team to achieve a shared vision, which is really what's transformational leadership. And I think that's absolutely vital. It's as important to our work as the clinical side of it. I mean, if we are able to lead teams, inspire our team workers, that's essential to leadership palliative care work. Facilitate cohesive multi or interdisciplinary working. Be able to define roles and boundaries which are acceptable to all. Manage day-to-day tensions. Oh, you didn't do this, I was counting on you to do it, but you didn't do it, and that's why everything went well. Manage those day-to-day tensions. Those are real. I mean, those happen on a daily basis. Facilitate day-to-day management, usually around logistics. Who's managing the transport? Who's making that phone call to the patient? To promote a healthy working environment. So, facilitate that environment where people are able to come and say openly what it is that their experiences have meant to them. What is it that we need to do to be able to work better, and so on. And to promote team support. So, be kind to one another. Respect one another, be honest, and celebrate successes as well as learn from failures and mistakes, and to be able to care for ourselves. So I'm going to leave you with a video from a music therapist in Cincinnati Children's, which was absolutely touching. It's slightly long, but I hope you enjoy.